Welcome back to the Therapeutics Chronicles. I'm your host Mu'min Wali, and today we are kicking off part 1 of our Steroid Masterclass, a 3-part series covering one of the most powerful tools in medicine, corticosteroids. And where better to start than with the most common and easily accessible route, oral corticosteroids. As pharmacists, we see these prescriptions constantly: prednisone, prednisolone, dexamethasone, hydrocortisone, crossing our bench in everything from asthma to arthritis. But while oral steroids can be life-saving, they are also one of the most misused medications in practice, often started with no plan for tapering or long-term risk mitigation. And that's where we come in. Before we get rolling, take a second to subscribe, share this episode with your pharmacy crew, and join our WhatsApp and Telegram groups. The links are in the description. And if you are someone who's caught a steroid mistake or prevented one, I want to hear from you. Connect with me on LinkedIn and let's swap stories. Let's start with a refresher on pharmacology. The backbone of most oral steroid regimens is prednisone, a glucocorticoid that's about 4 times more potent than cortisol. Its active metabolite is prednisolone, which we prefer in patients with hepatic impairment, since it bypasses the liver's need to convert prednisone. Then we have dexamethasone, a long-acting steroid that's about 25 times more potent than cortisol, with virtually no mineralocorticoid effect. That's why you use it in CNS inflammation, brain metastasis, or part of chemo regimens. Finally, hydrocortisone, which has a 1-to-1 glucocorticoid to mineralocorticoid ratio. It is more relevant in adrenal insufficiency than systemic inflammation. So where do oral corticosteroids show up? Practically everywhere. In rheumatology, we see prednisone used for lupus flares, polymyalgia rheumatica, vasculitis, and rheumatoid arthritis. In respiratory medicine, it is the go-to for asthma and COPD exacerbations. In neurology, dexamethasone is standard for cerebral edema or spinal cord compression. And in gastroenterology, we often dispense prednisone or oral budesonide for IBD flares, though maintenance therapy should shift to steroid-sparing agents as soon as possible. Let's talk tapering, because pharmacists are often the ones catching when a taper was not ordered or a patient does not know when to step down. If someone's been on more than 10 mg of prednisone daily for over 2 weeks, there is a good chance their HPA axis is suppressed, and stopping cold turkey could trigger adrenal insufficiency. The tapering process is not one size fits all. It depends on the duration of use, clinical response, and whether disease control has been achieved. Here is where pharmacy plays a huge role. If you are in a community and see a patient refilling a long-term prednisone 10 mg script with no taper or follow-up, that's a flag. In hospital, if discharge instructions include high-dose steroids without any titration schedule, we need to step in. Let's walk through a few real-world pharmacy-centered cases. You are in a community pharmacy. A 65-year-old man picks up prednisone 60 mg daily for giant cell arteritis. You confirm this is appropriate, high doses needed at first, but when you ask about tapering, he says, "I'm just supposed to keep taking it." You flag this to the clinic and the prescriber sends a taper plan. That one call might have prevented weeks of overtreatment and cumulative side effects. Another day, a 45-year-old woman with asthma picks up a 5-day supply of prednisone 40 mg daily. She's worried because there is no taper. You reassure her this is a short course and tapering is not necessary for regimens under 2 weeks. She leaves confident, educated, and more likely to stay adherent. Let's shift gears to long-term risks, because this is where pharmacy shines in preventive care. Chronic daily doses of 5 mg prednisone or more for more than 3 months significantly raise the risk of osteoporosis, infections, glucose intolerance, mood changes, and CV events. We need to advocate for bone protection. That means checking if the patient is on calcium, vitamin D, and often a bisphosphonate if indicated. Are we checking fasting glucose, mood, blood pressure? One of the most overlooked issues we catch is adrenal suppression after discontinuation. A patient who has been on long-term steroids and is now off them may still have adrenal insufficiency. If they get sick, injured, or need surgery, they may require stress-dose steroids. And yet, this is rarely documented in discharge plans or outpatient notes. If you see this gap, please raise it. You are also the one who can reinforce appropriate alternatives. Steroids are great for acute control, but rarely the long-term answer. If someone is picking up prednisone refills every few months for the same autoimmune condition, it is time to suggest revisiting the treatment plan with a focus on methotrexate, azathioprine, mycophenolate, or a biologic. Let's go back to some pharmacy-forward, accessible cases. You are counseling a 70-year-old woman who has been on prednisone 10 mg milligram daily for over 3 months. She's now on a PPI but nothing else. You ask about calcium and vitamin D and she says, no one told me I needed that. You explain that bone loss risk and recommend she speak with her doctor. That's a pharmacist-driven preventive care. A 40-year-old man is prescribed dexamethasone 4 milligram BID for back pain. You pause. It is not a standard indication and long-term use carries risks. You contact the provider, clarify that this was meant as a short course and suggest a plan for taper and reassessment. You have just spared the patient unnecessary exposure. Or a patient with IBD picking up their third refill of prednisone with no biologic insight. You send a note to the GI specialist asking whether steroid-sparing therapy is being considered. You might be the only one noticing that this temporary solution is becoming permanent. Now for counseling, this is where you bring it home. Let patients know when to expect symptom improvement, what side effects to watch for, like mood swings, insomnia, increased appetite, or blood sugar spikes. If they are diabetic or pre-diabetic, reinforce frequent monitoring, counseling on bone health, salt intake, and infection risk. And never forget to mention the importance of not stopping abruptly, especially if they have been on the drug for weeks or longer. Let's wrap up with some rapid-fire Q&A. What is the minimum duration and dose of prednisone that may require tapering? More than 10 milligram daily for over 2 weeks. Which steroid is preferred in hepatic impairment? Prednisolone, since it is the active form. What is the most common long-term complication of chronic prednisone use? Osteoporosis, followed closely by glucose intolerance and adrenal suppression. Does a 5-day course of prednisone for asthma require tapering? No. Short bursts under 2 weeks do not suppress the HPA axis significantly. What do we call the steroid that has the most mineralocorticoid activity? Hydrocortisone, with a 1:1 glucocorticoid to mineralocorticoid ratio. Which steroid has the longest half-life and minimal mineralocorticoid effect? Dexamethasone. What is one major counseling point for long-term steroid users? Stress the need for bone protection and adrenal considerations during illness or surgery. That's a wrap on part 1 of our corticosteroid series. Oral steroids are incredibly useful but dangerous when left unchecked. And pharmacists, we are the gatekeepers of safety here. From tapering to side effect monitoring to appropriate transitions, we make sure these powerful agents are used, not abused. If this episode helped you sharpen your approach to oral steroids, go ahead and subscribe, share it with your colleagues, and join our Telegram and WhatsApp communities. And if you caught a steroid mishap or helped build the taper that prevented harm, let me know on LinkedIn. I would love to feature your intervention. Until next time, this is Mu'min Wali reminding you, catch mistakes before they catch you. See you then.